I suspect that we're a mix of people who work in the health system, who use the health system, and people who have come along as citizens who have an interest in how we spend our health dollar and what we do with it. And I think it's testimony to the kind of interest in those questions, how many people have come along on a summer's night in January. So it's fantastic, and thanks to everybody for making the time. The first thing I'd like to do is acknowledge that we're meeting on the traditional lands of the Ghana people and pay my respects to the elders past and present, and also to acknowledge their resilience through the processes of colonisation. And I'd also like to thank the Hawke Centre for providing the facilities for tonight, both the venue and the very efficient process of signing up for the meeting. And also the organising group. This meeting has been organised by a consortium of the Public Health Association, SACOS, the Health Consumers Alliance, the Health Promotion Association, and the Australian Nursing and Midwifery Federation. And particularly, I think, to thank the organising group, Elizabeth DeBars, Ross Walmsley, Natasha Howard, Jeanette Young, Tori Saint, Kate Caminer, and Michael Howard. That's fantastic. And of course, to thank everybody for coming along to be a speaker. When I thought about tonight, I think there's really three main purposes of this meeting, which I hope some of you may have other ones, but I think these are the three main ones. Oh, and I should say that I'm Fran Baum, and I'm here in my capacity as a life member of the Public Health Association. The aims of tonight is we want to have a forum for discussion and debate about the health system and its future in general. I think that's the broad picture. Secondly, to respond specifically to the McCann report and its recommendations for metropolitan non-hospital services. And I think the third one, which I think is really important in any health system, in any democracy, is that it provides a space for citizens' voices, where people can be heard and people can have their views heard and listened to in a respectful way, but nonetheless we can put forward what we think about the direction of health policy and the direction of this particular report. It's certainly a time of turbulence and change in our state government, and it just has been in the last few days. The health minister we invited to come to the meeting isn't the health minister who's health minister today, and we obviously couldn't have foreseen that. That's the nature of politics. There's also, I think, a sense of crisis in the health system, and perhaps at those times it's really important to stop, think, take stock, and consider what is really important to us. What do we value in health systems as citizens, as health professionals, and as people who use the health service? And going back, I see it as going back to some of the basics. Prevention, promoting healthy, safe and sustainable communities, ensuring a health system's there when we're sick. And I think we really need to think about how do we best have a health system that does those things. So today, just to show you what we've got, we're going to start off with David Swan, and I'll introduce David, then Professor Leonie Siegel, and after each speaker we will have time for questions. I don't want you all to sit there and have to listen to speakers, so we can have an interaction thing. So as people are speaking, think about your questions so we can make most use of the time. Then after Leonie, Kay Mehta from Flinders University will speak, followed by Bianca Gazlola, sorry I probably said that wrong, who is also going to talk to people from the Communities Foodies programme. And then finally we hope to end up with something like half an hour for discussion and thinking where to next in terms of the work of this consortium. We'll go back to that one in a minute. So our first speaker is David Swan, and I'm really happy that David accepted our invitation to come and speak tonight, because he's the person who really, the buck stops with him when it comes to the health system. David, I think you've nearly been executive director, been CEO for 2 years. I think in March you will have been for 2 years. He's got vast experience in the health system, which has included over 4 years as chief executive of the Women's and Children's Hospital, and he's worked in both the public and private healthcare systems. So he's got an awful lot of experience at the coalface of health. And what David's going to do today is give his perspective and his overview on the McCann Review. So please welcome David, and then think of your questions for afterwards.
Again, thanks very much, Fran, for the invite here and the welcome invite. It's a great opportunity for me to talk to you tonight about the review that we had undertaken by Warren McCann. But before I start on that, I just want to pick up a couple of points that Fran was talking about, and that's the health system generally and the comment that it's in crisis. We have an excellent healthcare system here in South Australia by any standards, by both Australian and international standards. The life expectancy in South Australia is nearly as good as anywhere in the world. Access to services is extremely good by international standards, and I think we need to make sure that we see the system as a very good system by any means. What we are about tonight is really about evaluating how do we continue to look at the healthcare system, what are the needs for the community, how do we balance up the competing demands. And whilst the focus tonight will be on the work that Warren McCann undertook, the decisions we need to make are from a whole of system perspective about how do we actually maximise the use of resources that we have available for health in South Australia to benefit the community the most. And they are difficult discussions, they are passionate debates that we always have about where we invest, where do we make the best investment in healthcare for the community, and particularly how do we have that balance between the acute care sector and the primary healthcare sector in the broader sense to get a balance between the needs of all aspects of the community support. And I suppose where we'll be looking at is how do we actually get that right going forward. And tonight is an opportunity to have a debate and get feedback from all of you on the contribution that you feel that should be put into that broader discussion that we as a healthcare system will have to undertake. So again, I thank you very much for the opportunity to talk to you tonight about the McCann Review. I just want to give a bit of background to Warren. Many of you would know him. He's currently been involved with state government for many, many years, but his background was the Secretary of the Victorian Health Department for many years, so he has a long background in healthcare provision in Victoria, and he was selected for this role because of his experience in understanding healthcare systems, not only his association in South Australia, but particularly his involvement in Victoria over many years. So he is a very senior health leader of this country. So again, I thank you for inviting me to talk to you tonight. It gives me an opportunity to hear from you, your perspectives in relation to the review of non-hospital health services and inform where this review fits in the context of the current challenges of the healthcare system that I was alluding to. Today we have a valuable opportunity to contribute to the development of a well-informed position for South Australia's future of health services for government to consider. Like any organisation, SA Health has an obligation to continually review its operational performance. However, there's a range of circumstances, particularly over the past 10 years, that are significantly influencing the policy thinking that we have. These include pre-existing factors such as the ageing of a population, increased rates of preventable chronic disease, the increasing demand and cost for provision of health services across the state. In 2012-13 financial year, health spending will be a record high $4.927 billion for the health system in South Australia, $2.8 billion or 129% more than what we spent in 2001-2. A significant reduction in taxation and GS revenue has placed great pressure on the state's finances, and whilst SA Health continues to deliver quality health outcomes for all South Australians, its financial growth is unsustainable in this environment. Although the health budget won't be cut, this seems to be bouncing in and out a bit, sorry about that. The state budget requires SA Health to make significant expenditure reductions in 12-13, with the savings requirements growing each year until 15-16. There is a need for SA Health to deliver quality care more efficiently. SA Health has already been working hard to reform health services. This is to make sure we're providing safe, high quality and affordable healthcare now and into the future, based on good evidence of service delivery. In September 2012, we commissioned an independent review to look at the performance of outcomes of 235 individual non-hospital based services across our local hospital networks. The review followed a hospital budget performance and remediation review of hospital services within the metropolitan area and focused on the alignment of key services and service categories to the key policy objectives of SA Health as detailed in our healthcare plan, namely chronic disease management, hospital avoidance and population health. There is also a focus on efficiency and effectiveness as well as achieving savings. The recommendations in the Warren McCann review identified $14.9 million worth of savings and a reduction of 105 full-time equivalent staff positions by 14-15. The review supports a number of recommendations that have previously been identified by SA Health as part of normal day-to-day management initiatives, including hospital-based services. There are currently 6 hospital-based services delivered out of 3 metropolitan hospitals, and the recommendations in the report are that we should progressively transition these services and their funding to the hospital sector rather than the primary healthcare sector from 14-15. Integrated complex care for older people. We have 2 integrated complex care for older people services in the metropolitan area, delivered by service agreements with a shared provider. The recommendations are that funding should be remained for this financial year, with transition plan to support integrated functions within a mobile assessment team, another like service within our system. They believe that this will make savings of $370,000 a year from 13-14, in line with reducing administrative and overheads and corporate overheads. A practice nurse initiative, which we have 3 practice nurse initiative programs in Central, Northern and Southern, delivered via a service agreement with the Medicare locals, is recommended in line with the commencement of the service some years ago that this would cease on the 31st of December 2012, in line with achieving the objectives of the program. A residential care health care service support. There's a range of residential care support services delivered across the metropolitan area. Funding to these services should be ceased by the end of 12-13, and look at whether these programs fit other primary health care providers such as Medicare locals through our investigation. These recommendations are being looked at by the local health networks in consultation with relevant stakeholders and having ongoing consultation with both community consumer groups and also union representatives. The review also had some quite significant reforms to deliver around our non-hospital services, and this is really central to our public consultation that we are undertaking at present to see the recommendations from Warren McCann as to the change in service delivery for some statewide services. They include youth primary health care services. We currently have 3 services over 5 sites. It's recommended that the 3 existing services be replaced by an integrated service across the metropolitan youth, with 2 service hubs in the north and southern communities. The new service should have a focus on providing services that are consistent with policy objectives around vulnerable youth. And it's important to note that the funding should be maintained for 12-13 and a progressive reduction over the ensuing years as economies of scale and reduced overheads come to fruition. Health promotion services is also another area that was identified, and particularly the health promotion services within our local health networks across the metropolitan Adelaide should be reviewed and funding ceased from the next financial year. Children primary health care services, it looked at those, it was strongly of the recommendation that they should be retained given their service provision. Women's primary health service was another area. We run 3 services, and again it recommended that we move to a fully integrated service that has a clear service profile and program, and have savings from better integration of services in the north and the south, very similar to the youth services. Some local health networks are currently working on some of the savings opportunities, and as I mentioned before, we're very keen for the ongoing consultation with the community as they look at their local service needs. Going forward, the review and consultation feedback offers SA Health the opportunity to assess services in light of contemporary models of care and clinical practices, however, in regard to what constitutes primary health care in the SA Health context of our strategic plan. We should also be cognisant of the National Health Reform provides the opportunity to review and realign healthcare provision across the nation. SA Health has taken the opportunity to explore service provision and has commenced developing a statewide primary healthcare plan. The review provided the opportunity for SA Health to map out its service provision, assess duplication and system inefficiency. Your feedback will be included in further analysis that has been undertaken through the Youth Health Promotion, Children Primary Healthcare, Women's Primary Healthcare Service against a range of principles, including their target population obligations, the model of care and service provision, and who is best to provide the various services to the community. It is important to ensure that non-hospital based services will complement the recently established Medicare locals rather than duplicate or compete against them. Medicare local strategic objectives include improving the patient journey through developing integrated services, facilitating the implementation of successful performance of primary healthcare initiatives, primary prevention within the community through population health needs, and provision of primary prevention needs in line with the SA Public Health Act of 2011. There is further analysis and consideration required in this process. Your feedback, your contribution to the consultation process will be very welcome and valued. A consultation period concludes on the 4th of February 2013, and feedback can be submitted in writing, by email or post, or via our website. We consider the feedback and interest of the parties seriously before we will actually consolidate a response to the review undertaken by Warren McCann. So that gives you an overview of the review, particularly the important parts is that we've looked at it trying to make sure we maximise how it fits in with our strategic plan. The review also in relation to how we have competitive resource requirements from the acute care sector, the primary healthcare sector and various other aspects of health service delivery. And so in that context, your feedback on this review will be important in informing us of how we consider the McCann review. So thanks very much.
Thanks very much, David. I think, did I notice the new Minister just arriving? Is that right? Thank you, John Selling. So welcome, Minister. We're very glad you're here, and if you want an opportunity to talk. And we did say at the beginning that this is very much about citizens, about people who work in the health system and users of the health system getting to debate and discuss what kind of health system they want into the future. So hopefully that will be helpful for you. Okay, we're now going to open the floor for some questions. We've been asked, can you please only do your questions into the microphone because this event is being live webcast, and I think we've got quite a few people in the country and in other parts of the city, and they can only hear your question. So who would like to ask the first question? Thank you. And if people could just say who they are and if you're here as a citizen or from an organisation or whatever.
Hi, I'm Jeanette Young. I'm currently President of the Health Promotion Association here in South Australia. And I have another hat, which is that I lecture at the University of South Australia. Thanks very much for your time. Thanks for coming here tonight and talking about the review. I'm just concerned about how much feedback around the McCann response can really be responded to. So, for example, the Health Promotion Unit is already disbanding, people are finding other jobs, etc. My concern is that I've got students approaching me at this point and saying I need to think about other options because health promotion, population health is actually not going to be a pathway for my career in the near future. And so we're talking about population health being the answer, to a whole range of problems. We have the new Public Health Act, etc. We're not going to have a workforce, and we're certainly not going to have a workforce that can go to older people who've been there and done that, and done the hard yards and failed sometimes and got some things wrong, but also done some good stuff, because they're actually leaving at this point. And so we can give feedback in the next few weeks, but they're already devolving. And so it sort of seems to me, I'm not really sure you can value feedback, but if it's actually already happening, we're already losing ground at this point, and it's really valuable ground. So perhaps I'm just asking for a comment.
There really's got to be a balance between the opportunity to have consultation with the community. Once we have a review, obviously it does cause concern to the staff that are in affected areas. Many of them are here tonight. But importantly, we want to make sure we get the views of the community, the views of our staff, the views from our stakeholder organisations into those recommendations. Now, the difficulty we had Christmas in the meantime, so we've had to allow an 8 to 9 week period to be fair to everyone. We try and keep reassuring our staff and keep informing them and keeping involving with the process. But these are quite big recommendations that need some discussion and debate with a range of stakeholders. And so we'll just encourage our staff to be aware, make sure they're involved, and where possible just reassure them. But we have many staff that are still with us providing a range of services in the areas that you questioned.
Thanks. I think Elizabeth?
Elizabeth DeBars from the Australian Nursing and Midwifery Federation of South Australia. Thank you very much, David. Look, we're constantly talking about efficiencies and effectiveness of a service and the health service for South Australians, and we don't balk from that. We think that's a wonderful way to go forward, and you'll be very well aware that we often talk to you about solutions of moving that agenda forward. However, of course, you'd expect we're in the process of formulating our submission in response to the review. You might be able to help me though. When I read that review, all I see is some concessions that this is simplistic cuts, and it is about making an upfront saving now with no regard for the future. So I just want to understand from you, how will these cuts, which we do seem to be simplistic cuts, affect quality of service? Secondly, how will the Medicare locals in those circumstances where they're supposed to go over to the Medicare locals actually pick up the load in the absence of a transition or funding strategy? My next question is, how will that stop the blame game between the state and federal governments, which was supposed to be an outcome of previous health reform? And my other question is, how will the cessation or the cuts affect immediate or future demand? Because my real concern is that demand will only increase as a consequence of these cuts.
Thanks, Elizabeth. We just put a bit of context around. You'd all be aware, and particularly yourself would be aware, over the last 7 to 8 years, our investment into community health services has been quite significant and well past what has been contributed for the 20 to 30 years before that. In fact, there's probably an additional $60 million that's been allocated to a range of programs that are now operating in the community that have been put there to try and assist with meeting the objectives of our healthcare plan, which was a document that went out for significant consultation and has been universally accepted. And so there is a range of areas that we are investing in. What this report has done is respond to looking at our healthcare plan and saying what services are consistent with the objectives of that plan and what services are not consistent with the objectives of that plan, and try to evaluate them as to their difference they're making to the outcomes of the community. In relation to services and quality, notwithstanding the consultation process we're in now and how that may conclude, what services we do provide, we will ensure that they are resourced in an efficient and effective way. We're not moving away from providing quality healthcare to South Australians. There's something that we've been very strong in right across our system, and we will not shy away from that. In relation to the Medicare locals and the Commonwealth state issues, we're having quite good and mature discussions with the Medicare locals in relation to the opportunities to get better integration of service delivery. And we're highlighting the issues such as these reports. Now, that will take some time to mature, I acknowledge that, but importantly, we need to make sure that we don't have services that are duplicated and other areas of service leader just not being acknowledged by both the Commonwealth or state. And so we think over time that the Medicare locals are only been established over the last 12 to 18 months. They're very keen to engage with the state, and we think that those conversations will be far more productive than what they would have been years ago.
Okay, I think we've got a question up here, then one down here, then a couple over here. If people could keep the questions short, then we can get through.
Thanks, Fran, and thank you, Mr. Swan. I'm actually here. My name's Olympia. Can you hear me? Okay. I know it's better. I'd like to sit. I feel so nervous. I'd prefer to sit.
You're to try from here.
Is that okay? Okay. I'm really glad that I've had the opportunity to come here tonight. My name's Olympia. My trade is a nurse, and I took a package 2.5 years ago. It took me a year to land, but in the last year I've been really reading a lot about our past, like the past about community health. And I've just been fascinated by the history of how such community activity, such richness was happening back in the 70s and early 80s. And we struggled to get the word community participation into policies as we were doing it. And slowly we got swallowed up with policy, and now we are so full of policies and community participation and primary health care, but no action. And I think this McCann report really shows that up. And I'd like to read something to you today that comes from the Health and Social Welfare Council history when they closed up. They had a history from 1984 to 1994 to 2000 and something. And that was just when we were swept by the Victorian movement around Health and Social Welfare Council. So it was a very strategic time. But if you would allow my friend to read this quote.
How long is it, Olympia?
It's about a minute.
It's not.
Well, I think it's really quick because there's lots of people who want to ask questions.
The councils have satisfied most of the evaluation criteria and excelled in some, particularly in the explication of values of equity, social justice and efficiency.
Yeah,
Thank you.
That's great. So what you're asking is, like, what mechanisms are there for community participation now in the health system, given that that's historical kind of thing?
I'm concerned that we may have left our community behind.
Yeah.
And I really hope there is community people here tonight, because I really think that's the question we need to ask ourselves.
Thanks.
Well, I can only say part of the community participation is everyone here tonight. We're just giving you an opportunity to contribute to the debate.
I think Chris.
Hi David, Chris Morris from Public Health Association and Health Promotion Association, and you probably know me from a whole lot of other hats. What I'm a bit worried about, and you might not have an answer to this, is that there were a whole lot of reviews leading into the McCann review that cut dollars from a whole lot of other non-hospital services and primary healthcare services. Then we've had the McCann review. There's a 3% top cut off of, other primary healthcare, non-hospital services proposed in that. And I'm a bit nervous that this is the kind of first, there's a series of cuts. What's proposed past this? Is there another review of other hospital services, non-hospital services? Where do we go from here as far as you guys are concerned?
Well, just generally what we've been doing over the last 6 to 8 months is reviewing all of our operations. As I alluded in my presentation, health is $4.9 billion worth of the state's money. We do have a responsibility to look at how efficiently we're actually using those dollars. The community expects it, it's their money, and also how effective we're using that. Have we got the allocations in the right areas that maximise the benefit to the community? A lot of the reviews that you talked about before were really in line with this, looking at how do we get efficiencies across our system. And many of those recommendations identified where South Australia had opportunities to try to get to best practice in line with other states about how long people stayed in hospital, how much we paid for consumables, what is our power to procure all our medical requirements at an efficient rate. That was very strongly driven in the previous reviews which we're following up. And health will always be looking at how it evaluates itself, both from a service delivery, from an efficiency, and how we use those resources. We are a robust system that will continually need to evaluate itself to maximise what we're doing for the community. Because every time we find opportunities, it does mean that we can actually look at how we use those resources.
Paul Laris, Western Adelaide Coastal Residents Association. And thank you very much for coming along. I really appreciate you being here. I also appreciate the dilemma you're facing with the $4.9 billion budget that you're trying to control and even claw back. My question is, because it seems to me that the McCann Review is focusing on a relatively tiny portion of that $4.9 billion. My question is about where we might find other savings and why there perhaps hasn't been such a focus on it. And I'm wondering if you can enlighten us as to the impact of the last enterprise bargaining agreement with medical officers on that $4.9 billion cost.
The last enterprise bargaining... Hello, Paul. It's good to see you. You haven't changed. The enterprise bargaining agreement for medical staff, as it is for nursing and allied health staff, when agreed between the industrial body and the government, is fully funded. So it is in there, but it's like all the other agreements that do have increases, they're all funded within that amount. It's not as if it's an extra pressure on the system.
Hello, I'm going to take two questions. Did you have a supplementary question? No. I've got two questions, one here, one there, and then we'll go on to our next speaker. And you will have plenty of time for questions as the evening progresses. Thank you. Here and then up there.
My name's Trevor Lloyd. I'm interested also in the size of the budget being $4.97 million. And it would help me to put some context around this to understand how big that is as a percentage of the state budget and what it's likely to be in 5 years' time.
Well, it's a very interesting question, Trevor. It's about 33% of the state's budget, but it has been growing at a rate of about 8% per year over the past 7 or 8 years, while state revenue has been growing at around 2%, 2 or 3%. And you can see by that the contribution the state is putting on the health system is putting on the state is increasing its percentage of the total revenue of the state. Now that gets back to the debate about other agencies, about services for education, police, other areas that the government's got to make policy decisions on. Healthcare, as I noted in my presentation, has increased in funding since 2001-02 by 129%. It's a significant increase, $2.8 billion increase in funding in that time. And if you look at our funding on any national standards compared to any other jurisdictions, our health system is well funded, it's been well supported. But we do, as I alluded to before, we do have a responsibility, both from a budget perspective, but also on making sure we maximise how we use the resources that we're in charge of to benefit the community. And that's why we look at these things and we'll continue to look at them.
Okay, and one final question before the next speaker.
Hello, my name is Anne Bourne, and although I have a history of working in the health system, it's some time since I did, and so I'm here this evening as a private citizen. So I've not been familiar with the build-up around the McCann report, and so as I'm sitting here, though, I think my question probably is connected to what Paul was asking about, is what is the relative cost of hospital services and non-hospital services in budgetary terms, at the percentages, and you did allude, I think, to some of the reviews or processes that might have occurred in the past regarding ways in which, I guess, the things like consumables and those sorts of things perhaps more relevant within hospitals, but when has the most recent review of the effectiveness of hospital services and also the process of integration, and coming from a primary healthcare background and I guess an advocacy background, my concerns are, where is that integration going to, and the place for sort of debate about the ways in which things such as education, transport, the whole range of public sector activities impact on people's health.
Just your first part of your question between the hospital sector and the primary, well, hospitals will always cost a lot more money to run. But if you look at national benchmarks, and also part of the national reform agenda was setting up bodies such as Independent Hospital Pricing Authority. When you look at how we compare to other states, our system is funded quite well. And we do look at how we actually improve that, and that's why the first round of reviews we're focused on the hospital sector to try and work out what we're going to find in savings and opportunities for efficiencies there. So the broader argument is around the social determinants of health and how we. I mean, that's work that we want to do and we are doing across government about our health in all policies in some ways, trying to look at opportunities. But they're a long road, those processes and those policies, and will gradually change over many years. It's not something that we can change overnight, but it's something that we're very conscious of.
Okay, I'd like to thank David for actually coming into the McCann of Worms. I think it's really great that he's done that. So thanks, David, and thanks for engaging. All right, our next speaker is Professor Leonie Segal, who holds the Foundation Chair in Health Economics and Social Policy at UniSA. And Leonie has 30 years' experience in policy work, evidence-based policy work, and she's also looking at systems issues connected to primary healthcare reform. And she holds quite a few research grants, and I think you're also engaged in a number of policy committees, Leonie. So Leonie's going to speak for 10 minutes and then chance for more questions. Thanks.
So as a health economist, I suppose what I'm interested in thinking about is basically what are the criteria we might use to make decisions about really important questions about how we allocate our health dollar. Just, and I must admit this is AHW data, so it's a year or so out of date, but just to put on the table what is SA spending on public hospitals relative to public and community health, the other major areas of spending. The other thing I think is quite interesting is part of the reason the states are having such problems is the Commonwealth actually isn't meeting their obligation of 50% of the public hospital funding. And if they did, would be South Australia would be at least $300 million better off. So I think there's sort of issues around Commonwealth-state balance and how to actually put a bit of pressure on the Commonwealth. Let's get this to move on. So in terms of the McCann review, then I think what we also need to know is that they've identified $330 million of hospital spending and just focused on $78 million worth and recommended $14 million of saving. So actually we're looking at 4.4% of non-hospital services were recommended for saving. So just putting that sort of in context. What I want to do is think about the criteria that McCann used, and I suppose as a health economist, what's my view on that? Basically, he started off with identifying 3 health objectives, and in addition saying a service had to meet one of those objectives and be efficient in use of resources, both in technical sense, so it's the least cost way of doing whatever it's trying to do, and also cost effective in meeting objectives. Now, in terms of as an economist, I suppose the first thing to identify is that resources are scarce. We can never do all the things we want to do. And if we continue and expand some services, that means that there's less funding for other services. So in fact, the cost of continuing funding of some service is actually the benefit forgone elsewhere. So we actually need to be mindful of what are the services that miss out. And ideally, if we're looking to cut back, what we want to do is cut back those services where there's going to be the least loss in terms of health and wellbeing. And in a budget-constrained environment, we also need to be thinking about decisions' effect on budget. So the first thing to do is to eliminate any service where there's no benefit or where outcomes are worse, and it's surprising that there are still some of those around the place. And certainly that's one of the reasons for trying to really focus on poor quality care, because often that actually results in spending money to achieve worse outcomes. Looking at those that are technically inefficient, i.e. they're not doing things as cheaply as they could, and replacing them with things that are cheaper. But the biggest challenge is finding things that are cost ineffective. We're spending money, we're getting some benefit, but actually that benefit is less than what we could get if we spent it elsewhere. And also we need to consider societal objectives, which are particularly things like equity objectives, closing the gap. So in terms of McCann principles, how do they sort of map on to those broad health economic principles? Yes, he was concerned about efficiency. But I think there's an issue around the 3 objectives. I think part of that came out of doing a report in a very short time frame, so you try to do shortcuts, and one of them is let's look at programs where there is likely to be a benefit. But that doesn't necessarily mean the particular programs actually do generate the benefits that are suggested. Ideally, I think there would have been a greater focus on evidence, and I think the service providers have a major role in that, in supporting that capacity to make decisions on the basis of evidence. And I think ideally, in terms of budget impact, one of the challenges we have is a focus on individual portfolios, and yet a lot of what happens in health can improve outcomes in other portfolios. So if we can improve mental health services, we can have implications for criminal justice service, for child protection services. So we actually should be taking the budget as a whole and not trying to reduce cost in one particular portfolio. And also I think the report, the McCann report, gave perhaps scant attention to distributional objectives. I must admit, I've sort of looked through the various programs myself and just given some initial thoughts. It seems that there are a number of programs that clearly are Commonwealth responsibility, and particularly around general practice, and they're, I think, quite simple. In terms of things like the youth primary care, I think that's concerning, particularly in terms of this sort of cross-portfolio concept and the potential of these services to contribute to benefits across the system. One would want to look at those very carefully, particularly when we're dealing with very vulnerable populations, and think about actually what within that portfolio is working, what within that portfolio isn't working, and how can we ensure that only services that really aren't providing the benefits intended are cut. Children's primary health, that was, I think, important to see continued funding there. Health promotion, I think again the challenge is to really identify within that list of programs what is the evidence in terms of what's working. And I think without that evidence it's very difficult to make a decision about what within that should be cut. And one would hope that there might be some stay, but not indefinitely, but that there really is a major effort to get the evidence needed to make the decisions. In terms of the women's primary health area, I think it's very similar to the youth area. Again, a highly vulnerable group. One would like to have, I think, a greater focus on the evidence and whether the suggested service review really is achievable. I think often we think efficiencies are going to be achievable by combining services, and it doesn't always happen. I think again with a number of these, one would hope to have a bit more intensive look at the individual programs and see what particular benefits they actually are achieving. So in terms of making decisions about resource allocation and the sort of the response, I suppose, one of the things that I've looked at quite a bit is things like, is prevention better than cure? Should health promotion be protected from funding cuts? What's interesting, if you start to interrogate prevention better than cure, does that mean not prevention is worse? Does that mean we shouldn't be investing in cure for acute conditions? Shouldn't we be treating appendicitis? Does it mean we shouldn't be treating chronic conditions which extend life and improve outcomes? Does it mean we shouldn't be putting money into palliative care services or birthing services? And in fact, generally, studies suggest that the population do value these not prevention services. And other evidence suggests they actually make an equal contribution in terms of cost effectiveness. So there's an interesting study by a US study, and this is just looking at the cost effectiveness or cost saving, comparing preventive measures, and in this context it was actually primary prevention compared with treatment. And if you look across the scale, there's almost no difference. So there's nothing in principle that suggests a health promotion or preventive measure is going to be more likely to be cost saving or more cost effective than something else. It just goes back to we need to be looking at everything on its merits. We did similar work in Australia and found similarly almost exactly the same relationship between primary prevention, and we were then looking at secondary or tertiary prevention across the scale in terms of whether they're cost saving or not. So again, it just suggests that such sort of generalisations aren't going to be helpful in making decisions and to ensure resources that are allocated where they need to be. Similarly, there's often a view that population or universal services are better than targeting those at high risk. Now, in fact, whether that's correct depends on the particular circumstance, the type of program, the objective, the attributes of the program. And some of the work that we've been doing, which is particularly focused on, this is just a range of studies where and what I've highlighted in the yellow is studies which have a more health promotion, population focus. Other ones are often at the tertiary prevention or end. And in fact, there's no suggestion at all that the sort of population-based funding are likely to be more effective or cost-effective. In fact, often less so. So again, we just need to be very careful. This is some work we did looking at universal home visiting, and in fact, programs, services, we looked at 52 different studies, and those that were most targeted, the most high-risk group, were much more likely to be effective and cost-effective than the least targeted and universal services. That's not always the case, but it is sometimes. So just to finish off, in terms of the McCann review, I think some recommendations reflect change policy and funding context and make a lot of sense. Others, I think we need to be seeking further evidence, although we've got to be careful about lack of evidence not justifying continued funding. Efficiency gains, note they can be challenging to achieve and often involve loss of service quality and less innovation. In terms of making decisions, we've got to be careful not to make those decisions based on generalisations. Look at where services, for instance, are using evidence-based programs and then generating additional evidence. And I think there needs to be more support for the service providers who are so busy delivering services. It's very hard for them to have the resources and the time to be doing evaluation, which then they're called upon to provide in this sort of setting. So I think there needs a lot more support for that. Thank you.
Okay, I'll open the floor again. I think you were waiting last time, weren't you? Yeah, so there's a question up there, the person in the green.
Hi, I'm Kathy. Thanks for that. I work with Start Right, Eat Right and a mother of 2 young children. And my concern is with the McCann review that he was looking at that everything had to meet 2 out of the 3 criteria around population health, chronic disease and hospital avoidance. And for our children, that doesn't enable them to get anything because they won't get chronic disease till they're 40 and they won't go into hospital for a long time up.
Yes, I'd agree. I think putting those objectives as a sort of a first hurdle was unhelpful and it wouldn't be how you would normally establish priorities. one would want to look at each program on its merits. I absolutely agree with you.
Libby Calusi, editor of the Australian Journal of Primary Health. Thanks, Leonie. As an evaluator a while ago, one of the comments seems to be, you made the comment that programs should use evidence-based services and services should follow programs that are in accordance with the evidence. That doesn't necessarily provide evidence of outcome and evidence of effectiveness in the way in which they've done it. As you say, you still need a lot of support for ongoing evaluation, and it does seem like McCann has found places where there is no evidence of effectiveness, and that seems to be assumed that therefore that counts as evidence that these are not effective. And I think that that is a great pity, and that there does need to be a lot more attempt made, maybe in a longer time frame, to find what is effective and what isn't.
I'd absolutely agree. I think part of it is, my experience in working with some services around evaluation is often even by slightly tweaking the outcome data that's collected, one can already make enormous gains in terms of understanding what's achieved. So often I think the services themselves, if they're a little bit more aware of what evaluation data is going to be useful, can really make some quite major gains in terms of understanding what's being achieved. So I think if somehow that was embedded in the way people deliver services, I think we'd actually learn a lot more. But you're right, something being evidence-based doesn't necessarily mean it's going to yield the benefits that are expected, and often it doesn't because contexts are different. So yeah, there are major challenges around that.
Gary Golan from the People's Environment Protection Alliance. It's interesting in the reflection on the selected disease prevention strategies that were given. There's no reference to OC health and safety on work sites. There's no reference to pollution issues. If you take a look at the incidence of health disease in the Port Adelaide area where there's conflicted planning, the incidence is enormous. The cost is billions. We could put some priority there and make some huge savings. Would you like to reflect?
I think there's a broader issue around, these are looking at very particular programs, and it's not to say there aren't other programs that one would like to fund that might yield major benefit. So I think that's probably a separate exercise. Yeah.
Okay, I'm not sure who's got the microphone. There. Oh, thanks.
It's Elizabeth DeBars from the Australian Nursing and Midwifery Federation. I'm just taking a bit of a right of reply because you have criticised the slogan, which I in fact endorsed. In relation to that, absolutely we are not saying that prevention is better than cure means that you abandon attempts to invest in the area where it's about non-preventative work. We support both, but I stand by my comments which I've made in a number of forums, which are, isn't it better to avoid the issues if you can? And a real example of that is in the case of obesity. If you can avoid obesity, then you will avoid the huge costs associated with the care of an obese person. They do have much higher propensity for chronic conditions. There are far more complications with their treatment, and if you're talking about staffing and the cost impost that places on the health system, instead of one nurse per patient, which you might expect in the most acute circumstances, you can expect up to 4, and that is going to make a huge impost on the health dollar, I can assure you. The other thing I just wanted to notice, and I'm very pleased that someone else picked up on it, that the McCann review seems to constantly refer to the fact that there should be evidence, and you've mentioned evidence yourself. There is an absolute absence of evidence, and in fact McCann used that as a pure justification in order to put these simplistic cuts in place. I guess on that point, if you're talking about health promotion and there being no evidence, my question is, well, what is left if you take away some of these programs to encourage people to take better care of themselves, because the alternative is McDonald's ads and Nestle ads?
In terms of prevention better than cure, we've, I suppose, done an extraordinary amount of work in that space, and in fact obesity is probably one of your worst examples in that the evidence would suggest working with people who already are obese has by far the greatest effectiveness in terms of intervention, not actually working to prevent it. But and there are other areas that I think are extraordinarily effective. So I think it is important to take each program on its merits. But in terms of the issue of access to evidence, I just actually think at the end of the day, if we don't seek the evidence, then we can never be sure we're achieving the best we can for the community. So otherwise, if decisions, or if they're made on the basis of, otherwise they're going to be made on the basis of who knows what. So I just think it's just a plea that we actually need to move in that direction if we want to improve outcomes.
Okay, thanks, Leonie. Thanks for the contribution. And I think it's also important to say in the debate that when we talk about efficiency and effectiveness and prevention, there's a whole set of ethical issues about it's obviously better to prevent things than let people get sick. So, I think that's an important thing for us all to remember too. The next part of the programme, we're really going to dig down and have a look at one particular area, and this is the area of community nutrition. And first of all, we'll be hearing from Kay Mehta. I'll just introduce Kay in a minute. And then we'll be hearing from some people who have both worked and have worked alongside health professionals in the health system on a programme called Community Foodies. Kay is going to talk first, and then she will be doing a double act with Bianca and the Community Foodies. And Kay works with me at Flinders University. She's in the Nutrition and Dietetic programme in the School of Medicine. And she's worked for many, many years in community health centres, amongst other, as a community-based nutrition. And she also founded the national advocacy group, the Coalition on Food Advertising to Children. And I know Kay is completely passionate about reducing food advertising to children. But today I think she's going to talk much more about a community perspective and her thoughts about the McCann Review and community nutrition. So thanks, Kay.
So, as a nutritionist, I'll focus on the nutrition programs that have been slated by McCann to be axed. And these are some flagship nutrition programs for this state. They are Community Foodies. You'll hear a bit more about that. That's a peer education program where community people are trained as educators. Start Right, Eat Right, which is a nutrition program working with childcare centres to promote healthy eating, and the Eat Well, Be Active nutrition promotion officers. So let me just start by saying that, those of us who work in the public services, we accept in principle the need for reviews and reforms of our health services in order to enhance effectiveness, increase efficiencies, and unfortunately even to save money when we need to. But we require of our senior bureaucrats who undertake these reviews and reforms that they are logical, that they're progressive and not regressive, and that they're done in a respectful manner. So the logic of the McCann Review to me is baffling. How logical, the focus of the McCann Review, I'm sure you know by now, is on chronic disease and reducing chronic disease, keeping people out of hospital and so on. And chronic disease in Australia obesity is a significant contributor to chronic disease, and if you think that nutrition and physical activity are 50-50 of obesity, then at least 50% of the problem is nutrition and unhealthy eating. So surely the state's goal of reducing the prevalence of obesity and chronic disease will require continued and even increased investment in nutrition promotion, not defunding flagship nutrition programs. And if the McCann Review is suggesting defunding these nutrition programs, then how will the state improve nutrition and prevent obesity and chronic disease? That's just a simple, logical question. And if the community-based nutrition promotion programs are defunded, then the obvious thing that's left is clinical services, one-to-one services, and it's already been said, these are services that address the problem when it's already occurred, and notwithstanding Leonie Siegel's critique of prevention and treatment, we really want to be preventing these problems occurring, and that's cost efficiency. So, I don't understand the logic of defunding these nutrition promotion programs. The process is also highly questionable. So the McCann Review essentially is suggesting for these nutrition programs a transfer of funding to the Commonwealth via Medicare locals. To me, it would have made much more respectful sense to negotiate the transfer of responsibility for funding of these nutrition programs with the Commonwealth and Medicare locals, rather than axing them and just hoping that the Commonwealth will pick them up. So this doesn't seem like a logical or a respectful way to proceed. And what you're saying to those of us who, nutritionists and dietitians who've spent their careers working and delivering these programs for the state and for the community who've engaged it with these programs, is that they're not valued, and they'll be dumped by the state and left to the lottery of being picked up by the Commonwealth or not. And any of you who know about Medicare locals will know that they're GP focused, and GPs their primary skill base is in clinical services. So how efficient is it to devolve health promotion programs to essentially clinical services? And so just a word about nutrition promotion. I think we all know that it's complex, and improving population eating habits requires cultural change. Ultimately, we've got ourselves into a really bad state with more than 65% adult obesity, heading towards 80% in not too far away. And so what we need to do is to have this cultural change whereby people want to make healthier eating choices, and where healthier eating choices are easier for people. They're affordable, they're more available, they're promoted. And we know that bringing about cultural change is complex. It requires comprehensive, multi-sectoral approach over a long period of time. I think SA Health has shown amazing leadership by funding these nutrition programs that are tackling cultural change. And it defies understanding that we want to stop it at a time when we actually urgently need these programs. Some of you will have seen this document. This is the Eat Well, Be Active strategy for South Australia. I think it actually sets out a very intelligent course to bring about this complex cultural change, and it was endorsed by our state government in 2011. So what are we saying? Are we saying that we don't want this anymore? And as part of this strategy, the state employed Eat Well, Be Active nutrition promotion officers who were slated to be axed by the McCann Review. Why endorse a fantastic policy and then cut it at its knees? I just want to mention the issue of target groups and speak about the two nutrition programs, Community Foodies and Start Right, Eat Right. We know that population groups with social health risks, such as living on low incomes, having mental health problems, being a new refugee immigrant, being an isolated elderly, being homeless, these groups have higher risk of health problems, including obesity and chronic disease. These are the very same people who are known to be low users of mainstream preventive health services for a whole raft of reasons, but including that they're found to be threatening and unwelcoming. Community Foodies, that you'll hear more about, work with these target groups in a way that many other nutrition programs in the 20 plus years that I've worked in community nutrition have failed to do so. So the question is, why defund Community Foodies, and who's going to work with this target group to improve their health? Start Right, Eat Right works with childcare centres to improve healthy eating, and has achieved successful work with 80% of our childcare centres in this state. That's 342 childcare centres. All the research says that early childhood is a crucial time in the life course to build healthy eating habits. So why defund Start Right, Eat Right? And what's being put in place to encourage healthy choices in early childhood? A word about effectiveness. McCann stated in the review that there was no impact evaluation for the programs that he was focusing on. That just defies understanding, particularly focusing on community foodies and Start Right, Eat Right. These are big state-funded programs, and they've provided volumes of proof of impact evaluation. I wonder what data McCann looked at. If he looked at primarily service of activity data, then how can he judge the effectiveness of these programs? And if the problem is one of reporting or data management, shouldn't that problem have been taken up with the funder, SA Health, rather than axing the programs that were working at the community level? And this was working to the specifications of their funding agreements, and that includes impact evaluation. And they have been showing positive impacts on healthy eating indicators. You can get in touch with these programs to see their reports. In order to inspire confidence in the review, I think the report really should have detailed what evidence they looked at and should have ranked those programs against the indicators they were using. Otherwise, in the absence of the evidence of the evaluation, it seems like a witch hunt of those programs. Just a word about sufficient change, really. It can be argued that in spite of the funding of these nutrition programs, adult obesity has continued to increase. And this is putting a terrible burden on the health system to fund chronic disease. How do we know that adult obesity wouldn't have been higher without these programs? And are we prepared to take the risk about that? And childhood obesity is a bit different. It's still unacceptably high at about 23%, but it has been plateauing. And both Community Foodies and Start Right, Eat Right focus on family and child nutrition. So could we possibly say that the improvements we've seen in childhood obesity rates can be attributed in part to these programs? And are we prepared to take the risk of, removing these programs? Whoops, okay. Last point is really small funds for big value. The funding that would be saved from these programs, Community Foodies, Start Right, Eat Right, and Eat Well, Be Active, we've already heard it's a small amount of money, but they're really effective programs. And to pick up perhaps Olympia's point, they've been going for 10 years. They've built enormous trust and engagement with the community, and we're going to be breaking that apart for a small amount of saving that maybe could have been got somewhere else. Thank you.
We'll just open the floor for a few questions again before we move on to hear directly from the community foodies. So, did I? You've all gone quiet. I'm sure somebody's got a question. Yes, stand in the front here.
Thank you for your presentation. My name's Tracy. I was just wondering if it was possible to get a copy of it.
It's just a lot of scribbles.
Yeah.
But yeah, sure.
Or just maybe the basic points, because
sure.
I could really relate to what you were saying about being able to have confidence in following any pathways would be based on being able to,
Sure.
go with the logic.
Email.
So, yeah.
Thank you.
Okay. Sorry, down the front.
I just need to ask you, where does McCain think we're going to send our students from our cooking classes if foodies fold?
So this is a community member asking a question about where will the community go without the community foodies. There is no answer to that, and it's a damn good question. And you've been working with these really hard to reach target groups who have not fronted to mainstream nutrition programs. I know, because I've worked in nutrition for a long time in South Australia, for more than 20 years, and we have not delivered programs to those target groups until community foodies came along. And those are the groups that have worse health outcomes. And yeah, there's nothing being offered in place. Do we send them to the public hospitals for teaching classes? Well, I'm not seeing the public hospitals offer nutrition education in the way that you do. One-to-one service.
Okay, there's one here, one there, and then we'll move on to hear more. I think Emma's up there. And
I'd just like to commend you for asking where the evidence actually is, because I think that's what Leonie's talking about. It's what we really need to do. We do want effective programs. We don't want to be wasting public money, but it's very important for us to actually, for transparency, to see what evidence was actually looked at and what was the level. We have great ways of judging that evidence. So I have been in places that have questioned that, and I think it would be really valuable for us to actually see what evaluation was actually looked at for this review. So I commend you for raising that.
Thank you.
I'm a community foodie, and I've been a community foodie since 2005, and I've been very active across a whole range of people, old people, young people, people with mental health, and currently I run supermarket tours for people with chronic diseases. So where do I go from here?
Yeah, I think that's a big question for a lot of people there, and you know, there are no easy answers.
Okay, I think we've got one more person who I promise, and then we'll move on to hear directly from the community foodies.
Hello, my name's Catherine, and I'm a member of the ANF. And I have worked in primary health care in Aboriginal community-controlled health services, in what was originally separately incorporated women's health services that then became part of SA Health. And I'm currently working in primary health care services within Metro Adelaide. And I'd firstly like to acknowledge the shoulders of all the people that I'm standing on in my 30 years of working in primary healthcare services, and the lack of vision for our community now is so disheartening that it is no wonder so many servants of our community are putting up their hands for a package. And it's sad to see this expertise leave the sector when there are so many students from so many different countries that are part of our community look to primary health care, the spirit of public health, community participation. So it's been mentioned, and thank you for talking about community foodies, because it has been a program and a strategy that has seen, you know, we've redirected a whole lot of services into this strategy, and then to be insulted by the suggestion of even being described as non-hospital services. I know we're a small part of the budget, but that is insulting to start off with. But thank you, and I do hope that the new minister and whoever the new servants are can actually have a big rethink about foodies, because it does. It opens a doorway to people who probably don't even know how to access primary health care. And it makes a whole lot of sense to them.
Thank you.
Thanks for your contribution. And just introducing our next speaker, I'd just like to reflect that I do a lot of international work, as many of you know, with the World Health Organization. And it's always been a thing that when I go overseas, I can talk very glowingly of our community health movement in South Australia. And I think the one thing we have to make sure we do is build up that community health movement, I guess, to the level that it was in the mid-1990s. And it would be great if out of this kind of social movement we are able to do that, because, you know, it used to be possible to go overseas, and there was nowhere in the world that had, I think, the engaged communities that we had through our community health centres. And I personally think renaming them GP Plus and so on was a mistake, because I think community health had a lot of people understood what that meant. I don't think people always understand what primary health care means or what GP Plus means, but community health is a straightforward term. So I'm really glad to introduce Bianca Gazzola and her colleagues from Community Foodies. And Bianca is another Flinders graduate, well, is a Flinders graduate from the Nutrition and Dietetics Programme. She's had lots of experience at working in the Royal Children's Hospital in Melbourne, and she currently works coordinating the Healthy Murraylands project and has worked very closely with Community Foodies. So I'm handing over to you then you'll hand over to Kay to do the interview. Thanks a lot.
I'll be providing you with an overview of our South Australian Community Foodies program. You've already heard how it's being touched on through Kay's presentation and others. It is one that is recommended through the McCann Review to have funding cease as of middle of the year. So providing you with some insights, I'll give some background to the program for those of you that aren't familiar with the program, but otherwise hopefully to do justice to the program for those of you who are community foodies and here this evening as well. I'll also just touch on some of our evaluation findings, and then we'll hear from some of our own foodies and they'll share some of their stories. The program is Foodies volunteers working with local agencies to promote nutrition. Foodies have undertaken 28 hours of training in health messages and working with groups, and this isn't to mention the other work that they do in professional development and catching up as well. They're supported by local health services and program stakeholders. Priorities for Community Foodies program is aiming to build the capacity of communities to make healthy food choices by training and supporting community volunteers and members to act as agents for change. The priority target groups for this program are Aboriginal, CALD and low-income community members. Communities Foodies is innovative and successful in working with Aboriginal communities. The Aboriginal Community Foodies program, run through Port Augusta Health Service, was recognised for their fantastic work in 2011 as SA Health Award recipients for improving community wellbeing. Community Foodies began 11 years ago. It became a statewide program in 2003. It's undertaken independent evaluation since 2004. In 2006, it became a priority program of the Health Promotion Branch. Today, we have 20 community foodie sites across South Australia. Community Foodies works because it's built on partnerships. The program is collaborative and complementary to other health promotion programs. The program partners with agencies including local government, OPAL, healthy community initiatives, youth, domestic violence, many non-government programs, Eat Well Be Active teams, and many of these are our program workers. Start Right, Eat Right, Do It for Life, Country Health SA. Key partners include Housing SA, Aboriginal Health Council, TAFE SA, Red Cross, Royal Flying Doctors Service and Breastfeeding SA. The state team has trained many agency workers in the foodie training package to support our foodies across the state. The Foodies program is successful in attracting a relatively disadvantaged cohort of community members. In 2011 and 12, the evaluation report showed that 50% of foodies reported annual household incomes lower than $25,000. This demonstrates the program's reach to disadvantaged communities. You'll hear from our foodies shortly, but just to share with you a little bit more from the state evaluation findings. Today we have 290 active foodies across the state, including 44 Aboriginal foodies, 34 CALD foodies. Early last year, 201 foodie activities were run, 159 activities specifically targeting people on low incomes. 17 activities targeting Aboriginal people, and 39 activities targeting called populations. The Foodies program is so valuable to our communities. Foodies work with disadvantaged communities. Foodies break down barriers. Foodies are a volunteer nutrition workforce in the community, increasing access to health information, health support and health literacy. By being a part of the program, our foodies have reported increased confidence in nutrition knowledge, cooking skills, teaching skills for running programs. They have reported their own quality improvements in their diet. They've increased the number of serves of fruit and vegetables. Foodies have further self-reported and they've been found to be statistically significant changes in knowledge of how to prepare healthy meals, how to run healthy programs, their own cooking skills, teaching skills, consultation planning skills, and skills to work with others. With over 200 activities delivered last year, this equates to 10,000 volunteer hours. Sorry, I did have the figure for that, and it's not off the top of my head. $265,000. This doesn't include the indirect work, the work behind the scenes, the planning, the promotion, the making of resources, the making of food packets, the lobbying, the advocacy, the professional development, the other training and other information or other work that's happening behind the scenes. We have a quote here from Princess, one of our foodies from Central Eastern Foodies, that I'll just let you read. Another community foodie story, which also further illustrates the ripple effects that the program has into the community, I'll read for you. Sam was morbidly obese and had begun a weight loss journey at the start of Foodies training. Sam was very shy to begin with, but by the end of training, Sam had become more talkative, and due to her shyness, she wondered what could she possibly do in her community. She has 5 children, and if she can improve things for them alone and herself, that'd be great. However, to her credit, Sam has grown in confidence and enthusiasm to see improvements in her community over the past year. To date, Sam has lost approximately 50 kilograms herself. She helps weekly with the local home economics teacher with cooking, and she's started a vegetable garden with the local kindergarten where she provides healthy eating activities. A lesson in all of this is not to underestimate anyone, and that by providing someone with some knowledge and a supportive environment like Community Foodies, it can lead to many health and life-giving changes. Further evaluation findings captured from foodie program participants, so where activities have been delivered in the community, describe participants of our foodies programs as having chronic disease issues and diabetes or other health-related issues, just to capture their health disease or their health status. Just under a third of participants have reported attending due to an illness, either by themselves or a family member. So they're seeking programs and things programs to be a part of. Outcomes for the participants have shown that a majority indicated they had improved the quality of their diet. 3/4 of participants had learned to manage a health problem such as diabetes. For adults who participate in a foodie program, they've reported increased confidence in nutrition knowledge, increased confidence in cooking skills, learned to stretch food budgets, learned to manage a weight issue, and learned new recipes. These findings are further reinforced in a quote from a participant that I'll pop up on the screen for you to have a read of again. So for this one participant attending the foodie program, there has been a significant monetary saving in keeping him out of hospital, and he's just one participant. It's taken 11 years to develop this Community Foodies program. If it was to disappear, all the experience, all the expertise will be lost, and it's going to be pretty hard to reignite that kind of program again. Are we prepared to spend another 11 years rebuilding a program that will be just as cost effective and efficient? I'll now just hand back to Kay Meta, and we'll introduce two of our community foodies, Sonia and Ronwyn.
Thanks, Bianca. We're going to stand. I think we'll be better standing, don't you? It's my great pleasure to introduce Sonia Kling and Ronwyn McNichol, who are two star foodies from the Onkaparinga region, and they're, as you've heard from Bianca, they're two of 290 foodies across the state. They're all stars, really, but we'll hear from Sonia and Ronwyn. So I'm going to ask them some questions. What has it meant to you to be involved in the foodies program, Sonia?
Actually, I love being a foodie. It's basically been my life now. It has changed my eating habits. It has changed my child's eating habits. It's given me a self-esteem that, my self-esteem has basically gone through the roof, because otherwise I wouldn't be talking in front of you lot anyway. My grown-up daughters are now cooking healthy. My grandchildren are now eating fruit and vegetables, which they never used to before, because all they ate was meat. They have... my husband now is eating beans and legumes, which he never used to before. So it definitely has changed my life, and it's changed my family life as well. My cholesterol has gone down health-wise. I am being more active. Foodies has actually given me the incentive to do walking and more exercise. So without foodies, I wouldn't be what I am today now.
Thanks, Sonia. Thank you. What have you got out of being involved in foodies?
I did my training in 2000.
You can hold your mic up a little.
Sorry about that. I did my training in 2007, and I haven't looked back since. I've actually, look at it, I have lost over 50 kilos. Eating what I preach, which is eat healthy, eat plenty of fruit and veg, drink water and breakfast and whole grains, whole foods. And I love what I do. I mix with some wonderful students and participants and workers. Sonia and I do a lot of programs together. I think when she first met me, she thought, what on earth have I run into? But it is something that is worthwhile, and we love doing it.
We do.
We do.
Good. Thank you. I hope you could hear from that real and tangible health improvements for Sonia and Ronwyn and their families, the intergenerational effects, the life course effects of a foodies program for themselves, and you've heard for the people they work with. So tell us a bit, Sonia and Ronwyn, about what sort of programs that you run and who attends them.
The programs we run
We have done programs. I'm stuck. Personal employment, which is a disabled cooking class. We've done that for 4 or 5 years now. Sonia's only come on board last year because she did her training in 2011. We work with domestic violence unit. We do welcome lunches for the ladies there. And we've also just done a program about 8 weeks called Photo Voice, I think it was, where we did a lunch. And it was great because the ladies accepted they ate whatever we cooked and they helped with the dishes. And because cooking a meal and eating with people and students is a great way to get their confidence. And in some classes, if you don't have their confidence, you might as well give up before you start. What else have we done?
Yes, we've done supermarket tours with the disabled group. We have also done weekend work, as in community days. We've also stood in the supermarket and made pancakes and handed them out to people for healthy eating. So, and that was through Opal. Opal, yes.
And last year we went to Flinders Uni for Kay and talked to her students.
They're trainers as well. So Sonia and Ronman, you work with those groups that we call the hard-to-reach groups. And for many mainstream nutrition services, and there's many nutritionists here, often you get what's called DNAs, did not attend. People don't turn up to flash health services to attend those programs, those hard-to-reach groups. So why do you think those hard-to-reach groups attend foodies programs and maybe not attend mainstream health programs so well?
Because we're basic and down to earth, and some of us have probably been in the same situation. We wouldn't go to a community centre or to the doctor, whereas what we love about the foodies is we're backed by social workers, dietitians and health workers, and if one of them have got a problem, we can put them in touch with somebody without embarrassing them about it.
Mm-hmm. That's right. Thank you. And finally, what do you think participants get out of your programs that you deliver? What do they get from it? You mentioned confidence and stuff, but what some more? What have you observed?
A wealth of knowledge, I reckon, because we have found that there are people who don't know how to use a microwave, people who do not know how to use a knife to cut things up.
A lot of people don't know seasonal vegetables and fruit.
That's right. And shopping, they don't know how to shop.
And all of our programs are run with low budget. So the recipes we give them are what we cook for them and get them to cook for themselves and us. It is all within the average low-income earner's pay. Mm-hmm.
So what they do is what you see in policies being called health literacy, nutrition literacy, many of the things we take for granted, and we'd be surprised that people don't know how to use knives or microwave ovens, but these are really basic skills that are essential to health improvement, and foodies do that. It's really important stuff.
And both Sonia and I get a real kick out of, we might have seen a student for 2.5 years, and we run into them out of the shops, and the first thing they say is, I'm still cooking and eating breakfast, or I've run out of new recipes, can you get me some? Well, we go out of our way and we print them off and either drop them off to their caseworkers, or if they're on the email, we send them out to them. We are always accessible to our students, even if they've been 12 months away from our program.
Fabulous. Thank you.
One thing.
Yeah. And can I also say that we are pretty cheap. Oh, yeah.
Yeah.
So we are very cost effective. Yeah. And we don't expect much. And also for the government, I have a motto. It's...
Can you remember?
No, I've got to remember it. Eat healthy keeps government wealthy. Yeah.
One thing, when members of Parliament visit us, we do like to get dressed up photographs.
Okay, can
foodies. I'd just like at this point, just to make a point to Minister Snelling, that at Flinders we've just done a study where we interviewed 20 former health ministers. And one of them said being a health minister is a life against nature, so that's a warning. But they all talked about the tyranny of what gets on the front page, and it's usually something to do with hospitals. They bemoaned the fact that these stories that come from community health don't make it to the front page of the media. So I think, one thing I'd like you to always think as Health Minister is to remember what our community health workforce does, what our communities do, and that actually is every bit as important as what happens in the hospital and what makes it to the front pages. Okay, we've still got 15 minutes for questions, debates and comments. Mark Parnell, I think at the front there. Thanks, Mark.
Yeah, thank you. Mark Parnell, Greens member of the State Parliament, and I'm here with my colleague Tammy Franks from State Parliament as well. I'm not sure if anyone can answer this, but whilst the emphasis is on cutting programs, there are lots of other aspects of the health budget that are very large numbers, and I'm thinking of things like waste, which I understand is in the top 10, and also energy. Now, in other sectors, other industry sectors, cutting those two things has led to massive savings. So if anyone's able to say whether, if McCann didn't look at those savings, who else has, and do people think that should be done?
I'm just looking at David, and I think David's willing to come and have a comment on that one.
Yeah, thanks, Fran. Your waste is something that we're very conscious about right through our system, and it might be just the way we work that duplicates effort, or even things like hand hygiene that has infection rates that ends up people getting infections and staying in hospital longer. Our system is very conscious of trying to reduce waste, and generally we have a lot of quality indicators that are about trying to make sure the care that we provide reduces the chance of adverse events, which means people stay in hospital longer, which is a big cost to our system. We're always looking at how we actually streamline our practices and procedures to reduce waste, and it goes right across the board, whether it's the use of linen supplies, whether it's the amount of food that we provide consumers that ends up being wasted, whether it's other aspects of our service are continually being evaluated, and we're always looking at how we compare on a national basis to make sure that we can say that the dollars we spend in any area of our operations is consistent with national best practice.
Okay, thanks on that, David. Further questions? Ross?
My name's Ross Calusi. I have to confess I actually work in a hospital, which I actually enjoy, and we work closely with many community groups. I just wanted to make one point. We're going through a terrible time at the moment because we have all this evidence that what is going to happen to the mental health system is probably going to be disastrous, and nobody will listen to us. I want to make just 2 points. One is that there are two kinds of evidence, and one is, solid data-based evidence, which leads you in one track, and the other is what we've just seen with Sonia and Ronwin, which is a community kind of evidence, which actually you can measure, and you can show that those kind of activities increase the health of the community, independent of whatever they're doing. And we really need to love that and appreciate it. To destroy it is actually causes ill health. So what I want to say, and we see that time and again inside this institution called our hospital. So learning to think about the nature of evidence is part of the task that we all face, and that's a public exercise. It's not particularly hospital-based or public health-based. It's based on the notion of how we value things. And that's what I want to say.
Thanks, Ross. I'm conscious that most of the questions have come from the front. Is there anyone towards the back up there who would like to ask a question? Put your hand up. Yeah, there is someone right up. I can't see who it is. Haven't got my glasses on. I can just see a hand waving.
Hi, my name's Jesse Laris. I'm a member of the community, and I had a question for Mr. Swan. In the McCann report, as other people have already noted, there wasn't any real evaluation methods that were clear and set, and I even referenced the August Cabinet commissioned independent review of non-hospital-based services, with one of the key priorities in the top 3 being to establish an evaluation framework against which the services can be assessed for effectiveness. My question is, how does changing the actual service delivery model from what it is now to the Medicare locals address the issue of evaluation?
Is it going? Well, the evaluation, as I mentioned before, is an ongoing aspect of all our health services, and that's part of the discussion we're having with the Medicare locals. I think we're entering a new era of cooperation between what are Commonwealth-run services and state-based services, and how we get better integration of those services. We both rely on each other to provide a health system for the state. We both rely on each other to provide a health system for all Australians. And we'll be encouraging them in any of our discussions about how they evaluate their programs as we want to evaluate ours, because it gets back to my point that we need to make sure that what we're doing is effective. Are there ways that we improve the services that we're providing? Are there services we're providing that are not making a difference, that we should be looking at how we reorientate those services? And we'd be expecting the Medicare locals to be undertaking the same evaluation, given the limited resources and ongoing needs that they will have.
Just as a follow-up question to that, Mr. Swan, I'm just wondering how actually cutting the funding from those programs is going to help with evaluation methods. That's a question that I'd like answered, because we currently have programs that are running that are capable of being evaluated right now, today. You know, community foodies could be evaluated right now if we tried. But by cutting the funding and then creating new programs and delivering them through a new service delivery model, it's going to make the evaluation even more difficult and even more inefficient. So how's that going to help?
Well, that's true, but if you look at the document of the McCann review, he had, in addition to evaluating the benefits of those programs, he had three objectives that he was targeting that had to align the programs in line with our healthcare plan. And they were around how we had hospital avoidance, how we looked at chronic disease, and there's substantial evidence that the programs that we have in those areas are making significant difference to the community that weren't being made 7 or 8 years ago. So I acknowledge, but there was more than just the evaluation of programs that came into consideration of giving thought to what programs are important for the system and what programs can we look at reorientating, what programs fit in line with the Medicare local or the Commonwealth role. What is the responsibility of the Commonwealth government in relation to service provision in the South Australian healthcare system? They were all components that are part of the build-up that McCann had in giving consideration to the recommendations. Notwithstanding that the evaluation was a component of that, but it wasn't the sole component.
Okay, there's one more at the back.
Hello, my name is Vicky Bennett. I'm a GP. I've been lucky enough to work in hospitals and community health centres and Aboriginal controlled services and the RFDS, and I'm old. I guess 2 comments. One is to thank Mark Parnell for the question of waste, and really to just focus the thought back on the waste of skills that some of these recommendations are bringing. That's our biggest resource, and we are really blowing it. And the second thing is that as a GP, working in all sorts of settings, the most powerful tool I have ever seen for bringing people to medical care that would not otherwise get it are these sorts of community programs, no question. And And I think, paradoxically, when people who haven't accessed services actually start to get a service in the community, initially there will be an increase in hospital usage. Because if you've come from absolutely being terrified of anything to accessing a service, you will initially, whether you've got diabetes or alcoholism, you will initially use hospital services more, which again brings it back to the evaluation in the long term. So just the waste of skills and the personal commendation, and I think you could get this from anywhere, endorsement from the medical, clinical side, that this is the way. These programs are the way that we see more and more people who are otherwise marginalised. Thanks.
Two questions down here and one over here, and just while we're getting the microphone down, we've certainly done some research at Flinders that has shown that community development in health is a really important part of patient safety, so it really supports that as well.
My name's Rita Smith. I'm a citizen with a daughter with a progressive disability, and I'm wondering how the new Commonwealth Government National Disability Program is going to sync with the state health programs. My current perception is that currently children have better access to the kinds of services like wheelchairs and so on than adult patients. And I'm wondering whether this new Commonwealth Disability Program will make a difference to that. I'm not sure if it's too early to ask that question because I know the Commonwealth one's not fully developed yet. Does anybody have any answers to that?
I mean, is there anyone from a Medicare local who can comment on disability services? I don't know. I think it's a bit hard for David to comment on that. Yeah. So we'll take that as an important point, and I'm sure that can get fed into some of the considerations. So thank you.
Hi, I'm Elizabeth Becker. I work with Community Foodies, and I was struck by the comment that Vicky made, I think it was Vicky up the back then, about the impact on people who haven't had services, getting services, and I was wondering whether the Foodies, sorry to dob you in, Foodies, would be able to tell a story of change in participants who haven't had that access and what changes have been made. Just even one little story, because Foodie spoke about their own changes, but I know that there's been changes for the participants as well.
I was doing a program in the trying to think of the thing, Kulok House, which is an emergency accommodation. There was one young lady there that, with a child. She'd never eaten vegetables. She's never cooked it. But as we were doing the program with her, she actually fed some vegetables that we were cooking to her daughter. And her daughter loved the vegetables. So now she actually gives her child vegetables, even though the mother still won't eat the vegetables. But at least she's trying. And because she's passing on that knowledge to her daughter, it's a start.
Okay, thank you. I think we've got one question there, then one a bit further back.
My name is Della Davis, and I'm just a concerned citizen. I'm just looking at page 24 of the report, and there is a combination of $4.03 million for all of these services, health services that are purportedly done in the community, or are done in the community, I beg your pardon. And I just want to know, what is the Foodies' actual cut that they are getting cut, theirs alone? What is the figure?
Who can...
Somebody must be able to answer that question.
I'm Kim Voss and Liz Sanders. We're managers of the SA Community Foodie state team. The state team budget is $290,000.
So we are actually going to destroy something, Minister. I'd just like to say to you, for $296,000. Why don't we all tonight put our hands in our pockets, because I'm sure we could come up with a year's supply, at least to keep it going. I hope you're listening, Minister.
Okay, thank you. Then we will be drawing to the close because I'm sure it's coming up to 7, so we'll take just a couple more questions and then we'll close the forum.
My name's Helene Schultz. I'm from Lutheran Community Care, and so I'm probably representing part of a sector that's has many crossovers with the health sector, but I particularly want to, my concern and interest in this comes from a cross-sector project that has been happening in Peachy Place in Davern Park, one of the most disadvantaged and high-need areas in South Australia. And the cuts that will come out of the McCann review are going to not only impact directly on health workers and others directly involved in primary health, but are going to have multiplier effects across a range of sectors. And I'm just wondering to what extent is the South Australian Government considering those multiplier effects in both the implications of this review, but also in the provision of primary health more generally.
Okay, thank you. Again, I think we'd take that as a comment on notice, And then, look, there's people I've obviously ignored right up here are waving their hands, so if we could go up there and then come down to John, in the middle. There's some people up here who I've been ignoring behind the cameras.
Hello, Deirdre Veeney. I'm a community member tonight. I've just got a question about, a bit practical about the submissions that we can put in to the review. I thought it was customary to have a bit more of a framework that we could put in a submission, and I'm just wondering if David could answer the question, if there was a preferred kind of structure that we could perhaps adopt.
No, we're really leaving that up to you to respond. I suppose from our perspectives, if you can relate your response to the various recommendations so there is some relationship between your comments, it helps us evaluate them. If they're general comments, we can take them on board, but it's really the recommendations that we'll need to evaluate and give consideration to. So if there is a relationship with that, it does help us understand your views and take them into consideration. But generally, letters or emails or however, but there's no structured format. We're just keen to hear your feedback for us to consider.
Well, then I think we'll have to make this the last question because I think, is there anyone I've really missed up the back because I'm conscious? No, so, okay.
Well, this is actually a question to you, Fran, because earlier this evening you alluded to the possibility of using this forum tonight as maybe a stepping stone to, I guess, sort of invigorate and bring together people interested in maintaining and putting forward advocating around community health, public health issues. And if you'd had any thoughts about how that might happen from here.
From the chair, yeah, I mean, I think the organisations that put the event together, the Health Consumers Alliance, the Australian Health Promotion Association, the Public Health Association, SACOS and the ANF, each of those organisations have very clear policy statements. So I probably, know the policies best of the Public Health Association, and which has a very sophisticated policy process. And we're very clear that comprehensive primary health care along the lines of community health is by far the best basis for a health system. Got absolutely no doubt about that, with a strong focus on equity, social justice, and which addresses the social determinants of health. So I think this coalition, I think I can say, will continue to be monitoring McCann and what happens and the cuts in the health system. A petition has been established that's an online one and I think a virtual one. So the organisations will continue to work together to lobby, to advocate for their policy positions. And I know each organisation would like to say, if you're not a member and you'd like to be a member, there are of course membership forms out on the table. That would be very important. Is that enough, or yeah? And so I think it's, the link is with one of those organisations to get yourself on the mailing list and, keep that policy voice going, I think. So I think now we'll bring the forum to an end. I'd really like to thank the Minister for sitting and listening. I think... In my experience, it's very rare for a minister to come and sit and listen as attentively as you've had, and I think that's a very good start for your tenure as Health Minister for Community Health and Primary Healthcare Services, so thank you. I'd also like to thank particularly those of you, and I know there are many of you here, who are citizens and users of health services, because my real belief is if we're ever to solve the problems that we face with health services, it is going to be through engaged debates with citizens about what sort of health system they want, what they value, where they think the money should be spent. So I'm really glad that so many of you came along tonight, and to people who are members of the health workforce, who I know at the moment, because I've had many calls from people who are feeling threatened, who are feeling undervalued, and who are feeling that their work isn't appreciated. And I'm sure that wasn't the intention, because I think you can see the response from the people here today that your work is extraordinarily highly valued. So thanks everybody for coming. And can I ask you, if you want to sign the petition, it's outside, to get yourself on the mailing list, to link up with the organisations that are here. I know there are some residents groups around the city who want to join the Alliance, and I think that will also be fantastic. So once again, good night and thank you.